This is TTT Live. I'm DK Roster. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Chalk City 91.1 FM, Sweet 100.1 FM, and on Facebook at TTT Live Online. Now over to the Minister of Communications, Donna.
Good morning and welcome to today's virtual media conference. Today with me are the Minister of Health, the Honorable Terrence Deyalsingh, the Chief Medical Officer, Dr. Roshan, and Dr. Avery Hines, Technical Director, Epidemiology Division at the Ministry of Health. The Minister of Health, the Honorable Terrence Deyalsingh, will provide an update on COVID-19 in Trinidad and Tobago.
Thank you very much, Minister Cox. Good morning to the Chief Medical Officer, and this morning we also have Dr. Avery Hines, who will be sharing the latest epidemiological update to show you how the contact tracing has been going. It's been a while since I gave the global picture, and the global picture continues to increase. There are currently 18,299,299 cases, 18,299,299, odd number. The number of deaths, 693,957. The average daily cases continues to be in the range of 200,000 to 250,000 per day. So there has been no significant decrease in the number of daily cases. The top 4 countries basically remain the same. United States with 4.8 million, Brazil with 2.7 million, India with 1.8 million, and Russia with 856,000. What is happening locally and regionally on a policy level? We got some good news recently from the British High Commission, which I want to share with you, because this speaks to country cooperation as we seek to find, I'm using the term here loosely, the infamous magic bullet to deal with COVID. So on Wednesday, May the 5th, there will be a virtual meeting with stakeholders to accelerate access to COVID-19 tools in the Latin America and the Caribbean. And Trinidad and Tobago, being one of these partners, will be most present, either through the Chief Medical Officer or Dr. Avery Hines or Dr. Naresh Nandram. The purpose of this virtual meeting is to discuss and promote international and regional cooperation in securing vaccines, therapeutics, and diagnostics, commonly referred to as VTD, vaccines, therapeutics, and diagnostics. Because Trinidad and Tobago will have to understand, as the letter says, how that multilateral architecture around VTD is developing, and we want to be a part of it. It will discuss how vaccines are to be financed, self-financing of vaccines, and the policy allocation for vaccines. How will vaccines be allocated amongst different countries based on their income levels? So Trinidad and Tobago is firmly in a driver's seat when it comes to participating in this international effort. And this is some good news coming out of the whole response to COVID-19 around the world. Ladies and gentlemen, you may remember last week we would have discussed the issues surrounding contact tracing and some of the problems we were getting with contact tracing, where it was difficult to find people. People found the questions were a bit invasive, persons not answering questions correctly. Today with Dr. Hines, who will go into details, I just want to give the country the ease of mind to explain the policy position behind contact tracing and how important your role is in combating this virus in Trinidad and Tobago. When we call for information, you have a very, very important role to play. So what is contact tracing for COVID-19? It is an integral part of a comprehensive strategy of critical activities to reduce transmission and control the spread. And that is what we are trying to do now in this phase of our local epidemic. Reduce transmission and control spread. It helps us identify the cases, helps us test, isolate, treat. This is very, very important if the country is to continue, with economic activity and so on. The main objective of contact tracing is a simple one. It is simply to break the chain of human-to-human transmission, to make sure that the number of new cases generated by one person falls below 1. And the Chief Medical Officer will explain what that 1 is. It is called the effective reproduction number. It simply means if you have COVID and we could successfully interview you and contact trace everyone, the chances of you infecting more than one person is significantly decreased. Significantly decreased. And that will help us from achieving community spread and so on. What are we doing? What are the critical elements of contact tracing? 1, we know there are legal and ethical concerns for privacy and confidentiality. And one could admit we have always protected the confidentiality of patients, even though when we are asked to disclose names, locations, and so on. So when we are contact tracing, rest assured that from the very top of the Ministry of Health, we have always sought to protect patient confidentiality. All the staff who will be contacting you have been trained in contact tracing and will strictly respect the confidentiality guidelines and adhere to all ethical and legal regulations. Efforts to locate and communicate with contacts is carried out in a manner that preserves the confidentiality and privacy of all concerned. Whether you tell us who you are living with, who your family's members are, who you met with, their confidentiality is also preserved. And we will never, ever give out the names of the persons to third parties. If we get the cooperation of those we are contact tracing, it could lead to very rapid identification of cases, whether those cases are in your primary contacts, secondary contacts mainly, and so control the spread of the virus. Because as we keep saying now in this phase, we have to learn to live with the virus. We have to learn to live with the virus. So we are asking again, when we contact you, to be upfront, honest, truthful. Your cooperation will go a long, long way in managing our local scenario. In closing, Minister Cox, it will be remiss of me if we don't again once more use this platform to ask for the considered cooperation of the public in taking it into your daily routine to do the simple public health measures we have been asking for, that Dr. Trotman spoke about last week, Friday. These simple things. It's the simple things in life. We have a saying, the simple things in life are free. Well, these simple things will help us really manage the situation we are in. That is to wear masks. We are not at this time considering making masks a legal requirement for all sorts of reasons we have discussed, but we are urging persons, once you are out in public, to wear a mask. We are asking proprietors, business owners, malls, any place where people are coming into your premises, the same way you have signs up saying no bareback, no slippers, no short pants, which you enforce. To enforce a no mask, no service policy. Enforce it. We are also asking the population to adhere to another series of guidelines, simple ones. If you are ill, please stay home. Get checked out, get tested. Isolate yourself. If your child is ill, let them stay home. Sanitize your hands. Wash your hands as frequently as possible. Walk around with a little sanitizer. Any opportunity to wash your hands, wash it. And avoid the hard surfaces like door handles, especially in the public domain. You're going into any sort of facility, make sure after you touch the door handle, you go inside, wash your hands. Proprietors, clean down your hard surfaces, your door handles, your touch surfaces as frequently as humanly possible. These simple measures, together with physical distancing, will help us beat this virus until we have a vaccine, until we have a cure, until this meeting we are attending on Wednesday brings out some more concrete measures. So that is the state of play as we stand now. I will hand over to Minister Cox, who will then go to the Chief Medical Officer for his clinical update, and then to Dr. Avery Hines, who will tell you more about what we know about the epidemiology of this current phase that we are in. Thank you very much, Minister Cox.
Thank you very much, Minister. But before I go to Dr. Pasram, I would like you to just confirm the date of this meeting.
Sure.
The virtual meeting.
Yeah.
Because I believe you said May. So
sorry, I apologize. It's on Wednesday, 5th August.
Yeah.
That's the day after tomorrow at 9 a.m. And the meeting is entitled Accelerating Access to COVID-19 Tools in Latin America and the Caribbean. So Wednesday, 5th August, I do apologize.
Thank you. Thank you very much. At this time, the Chief Medical Officer, Dr. Roshan Pasram, will provide us with a clinical update.
Hi, good morning, honorable ministers, members of the media, Dr. Hines, members of the viewing and listening public. So our clinical update for Monday, 3rd of August, 2020 is as follows. Total number of tests done, public health, as well as the Caribbean Public Health Agency, 8,570. The number of unique tests submitted, 6,984. Total number of tests repeated thus far, 1,586. The number of community tests, 4,282. Total number of private sector tests, week ending 31st of July 2020, now stand at 2,007, bringing our total number of public and private sector tests conducted thus far to 10,577. The number of cases that are now positive are 182. We would have gotten our last 2 cases yesterday. Just before 6 p.m., we would have put it out in the 6 p.m. update. There was one case that was definitely linked to one of the other contacts. And the second case, there was little information on the actual form. So we have begun the tracing for that individual. And of course, that both persons would have been sent to the hospital, Cora Hospital. In terms of total number of discharges thus far, 135. Number of deaths remain at 8. The total number of hospitalized people we have right now, 39. I'm happy to say that all 39 individuals are clinically doing very well. The person that was on HDU, as I said a few days ago, was brought down back to a ward setting and is doing well as well. So we are looking at maybe later on in the week to possibly decant, as we have done in the past, a lot of those individuals to step-down facilities so that we await their discharge criteria. And once their discharge criteria are met, they can be discharged home. But it will allow us to free up some space in the secondary and tertiary care facilities in the event that we do have additional cases. So the split in that 39 are 35 individuals at the Cora facility and 4 persons at the Cuba Medical and Multi-Training Facility. As it relates to our quarantine individuals, we have, if you take out the CPL cohort, and I will go into a little more detail with the CPL group, we have 106 persons in the regular quarantine facilities spread across a number of facilities. We began to use Arima General Hospital as a suspect facility a few days ago, so we have 2 persons there. We have 4 individuals quarantined at the Cora Hospital. Those are adults linked to children. The Cuba Medical and Multi-Training Facility, we have 1 quarantined individual At the UE St. Augustine Day Bay campus, there's 1 individual only now. Chancellor Hotel, 12 persons. At the Napa, where we have our healthcare workers, we now have 10 persons. At the Cascadia Hotel, we have 18 individuals. There's no one at the Takariba facility, which is the facility we'll probably be using as our step-down facility for those patients later on in the week. Home of Football, there are 13 individuals. At the Regent Star, 45. And as I said, with the CPL so far yesterday, we have gotten 102 persons. They're all at the Hilton Hotel. The swabbing is in process, being led by members of the medical team. And that should be completed, I think, later today. We expect 67 additional persons to come in on a flight later today to join that group. All of them are in strict quarantine at the Hilton Hotel at this time. Minister Cox, that's my clinical update for this morning.
Thank you very much, Dr. Pasram. Dr. Avery Hines, Technical Director, Epidemiology Division at the Ministry of Health, will provide an update on contact tracing and give a comparison of cluster versus sporadic spread. Dr. Hines?
Thank you, Minister Cox. Good morning to the Honourable Ministers, to the CMO, to the members of the media, and the members of the viewing and the listening public. Today, I'm going to summarize and explain a little bit about the process behind the contact tracing. I'm going to show a couple images, maps of what we have been seeing with regard to that contact tracing process. And then we're going to speak a bit about some of the findings, the things that have been revealed as the contact tracing process has unfurled itself. So for starters, as the Minister very succinctly put it, the contact tracing is an integral function of us making sure that we know who has been exposed to potential infection and making sure that we get ahead of potential chains of infection. When we contact trace, what we do is we reach out to the persons who would have been identified as having been in direct contact with an identified case. So those would usually be family members, household members, whether they are blood related or not, members of the workplace, places where they would have been in gatherings in close proximity. So those are the questions that we ask each of the people that we reach out to for contact tracing. So we ask the cases, and when we identify those primary contacts, the people in direct contact with the case, we expand the circle. So those persons in turn will be called and they will have questions posed about their demographics, age, sex, etc., their location, where they live, their workplace, where they work, who lives with them. And while it may seem as though we're asking a lot of personal details, what we're really doing is we're trying to determine how many people may have come into what is considered significant contact, into contact for a prolonged period, upwards of 15 minutes, within close proximity, within 6 feet, because that's the sort of definition that we're using, according to WHO's guidelines, for identifying what potential transmission-related contact might look like. Now, having done that, we generate information and put it on maps to get an idea of what we are seeing across the country. So we have a few of those this morning. The first being the overall map of all of the cases that we would have identified between the start of the epidemic and this point in time. So that would include the cases identified between March and the end of April, and those would be in red. It would include the cases that would have been identified as part of the repatriation process who came in and were directly quarantined, and those would be in purple. And it would include this next group that we are following up, that are cases identified, and we're calling them local cases. They are linked to other cases within the population, and we've identified them as clusters. So those are shown in blue. To simplify, we're going to go to the next graph, or the next map rather, which really just shows the second set, so not the group between March and April, but the group that we would have seen beginning with the repatriation process and continuing to date. The repatriation, once again in purple, identified by the sites, the quarantine sites where those persons were held, and also showing the cases that popped up in the population. And at next level, we see the relationship between the identified cases and primary, secondary, and tertiary contacts. the importance of this being that although we have a relatively limited number of local cases in clusters, those clusters are still geographically spread across a wide area, and that is because of the nature of human interaction and maybe Trinidadian interaction in particular. So what we want to emphasize is some of these settings in which we have seen that transmission would have occurred. When we look at the clusters, meaning the groups of related cases, we've seen that people who shared household space have, in some instances, managed to transmit infection to other household members. We've seen that people who share workplace space, in some instances, again, may have managed to transmit to the members of their workplace. Clearly not all of them, but there have been a couple related cases along those lines. We've also seen that in social settings, social gatherings, bars and other gathering settings, that people are capable of transmitting whatever illness they have because they remain in close proximity, possibly plus or minus the health enhancing regulations that we've been promoting and advocating and sometimes begging for, of the hand washing, the mask wearing, the physical distancing. So in any settings where you don't have adherence to those, there's an increased risk of anyone with an illness transmitting it. So we saw that happen in some social settings, and we also saw a couple of school exposures directly related to adults who had been infected in one setting or another, and then they would have exposed the school-aged children, and where those school-aged children happened to be in SEA classes. That led to exposures of schools and closures of several schools to date. Emphasizing really that the behavior of the adults, the responsibility of the adults in protecting the vulnerable members of their family, both the young ones and the older ones, that behavior but to protect your family members is of utmost importance in reducing the exposure and the potential spread of COVID-19. So we have found among the cases that we've identified to date that several of them have been, as we said, interlinked, either family members, workplace, or social gatherings. As we get more information on new cases, we have actually found that some of the cases we thought weren't initially linked are actually linked to some of the social gatherings that we had identified previously. So we are getting the sense that there is some sort of relationship between the vast majority of the cases that we've been able to identify, and we are continuing the process of the swabbing, the quarantine, the advice on sanitization of exposed settings, whether it's schools, workplaces, etc., in an attempt to reduce the risk of transmission in any of these settings. I'm going to wind it up there, and I'm going to turn over to the Minister of Communications.
Oh, thank you very much, Dr. Hines. Members of the media, the floor is now open. Remember to identify yourself and the media house you represent before posing your question. And we want to give as many of you an opportunity to pose questions to us. But that means in our limited time, we will have to give each media house a chance to get a maximum of 2 questions in. And once we have completed the pool and time allows, I will come back to you. So let us keep this in mind as we begin taking your questions. AZP News.
Hi, good morning. Priya Bihari, azpnews.com. I just wanted to find out a little bit about the testing. You know, there have been a lot of calls for us to do more testing. Dr. David Bratt, for example, has called for more testing, and have compared a number of the countries in the Caribbean who have done sometimes 10 times the number of tests that we have done. My question is therefore, do we only test symptomatic people? Must we only test symptomatic people, or do we test asymptomatic people? And is it if that is the reason why we don't have the numbers as other countries with a population less than ours? Thank you.
CMO.
Okay. So our testing protocol, as you know, has always been aligned to both 2 things. WHO in the first instance. So WHO PAHO has given guidance from the very start of this epidemic as to who should be tested based on a clinical criteria. And the Ministry of Health in Trinidad has always utilize that testing facility, as well as you know, in the early parts of the epidemic, Caribbean Public Health Agency was the lab for the Caribbean that would have been testing. So they have their own definition, which is aligned to the WHO definition. So our testing would have been clinical cases that show signs and symptoms and meet a certain definition in the early days. As any epidemic progressed, we changed our definition to include, when we thought we had local cases, to take out travel-related, for instance, and test beyond that. We have always been testing people that had severe acute respiratory illness throughout the epidemic. Our numbers were very small in the early days in terms of cases, and as you're seeing now, as you have contacts, so if you have five cases of any disease, we usually test around our contacts. So we do primary, secondary, tertiary. We follow them up for 14 days, and the testing will increase. If our total number of cases are low, and our total number of viral illnesses that are presenting, and as I said before, our viral illnesses for the last 2 months have been extremely low both at secondary care and primary care. We test based on who presents to us, as well as who has been linked to any case. So primary, secondary, tertiary, or anybody presenting to the facility for viral illness. Bearing in mind, of course, that testing has always been and will be continuing to be a voluntary process where people can say no. So it is a lot of things, but I think Trinidad has always kept to the definition of testing, and we had from the outset, we continue to test all the viral illnesses that present as much as people allow us to the facilities. You would have noted over the last 2 weeks or thereabouts, our testing in the community has increased significantly. The reason being, of course, that we have cases, we have a lot of primary, secondary, and tertiary contacts. We did, even in the start of the epidemic, when there was a strong link, for instance, when someone is exposed, family member, for example, to a case, we would have tested those individuals as the only exception as asymptomatic people, and we continue to do so. So we will test those individuals with very high levels of exposure, primary contacts, to make sure that we start the primary contact testing, and then we do that again at day 13 of your quarantine to ensure we're not missing any cases in that highly infected or infectable group. You have seen that we have done this with the cruise ship cohort as well, because as you know, they have behaved a little bit differently in terms of the way the virus. They were very high viral loads, for one, and they were in very close contact for long periods of time. So in those particular groups, we would have tested those individuals.
Let me just come in here. Mm-hmm. So the CMO has explained the technical aspects of testing. I think what keeps getting lost is the policy aspects of testing. Mm-hmm. And not only policy aspects of testing, what a country does to mitigate the importation of the virus. It must always be remembered that Trinidad and Tobago took the first proactive step in the Western Hemisphere on January 30th by prohibiting travel from China. You must have spent 14 days outside of China before coming into Trinidad and Tobago. That obviously will break the chain of transmission, which will have a positive impact on the number of tests you have to do. We also enforced strategically other countries where we were not allowing people to come in from. France, England, Italy, Iran, South Korea, and then we had a total border closure. We were very proactive, and when you do those things, the risk of the virus coming in is significantly lessened. Therefore, the pool of possibly infected people is significantly less. Therefore, the need for testing becomes significantly less. We also did the shutdown of the country for a couple of months. Remember that, where everyone stayed at home. That will have a positive impact on viral transmission again, and therefore less need for testing. What we always reminded members of the media was that countries that did asymptomatic testing, especially in the early days, live to regret that. Because in the early days, when you did asymptomatic testing and got all these negatives, it lulled those countries into a false sense of security. We did not go that way, even though there was a lot of pressure on us to do that. And the last thing I want to say about testing, and I have played the clip on this station, and if the producer can find the clip. Dr. Tedros made a statement, but his statement was taken totally out of context. He said, test, test, test. I don't know if you could find the clip. And everybody latched on to that. He said, test, test, test. But what nobody realized was that in the body of that speech, he said, test all symptomatic persons, isolate them, and treat them. So testing asymptomatic persons for the sake of testing, just to get your numbers up, does not make good sense. And I don't know if we have the clip. Do we have the clip that we could play? Yes.
We have a simple message for all countries. Test, test, test. Test every suspected case. If they test positive, isolate them and find out who they have been in close contact with up to 2 days before they developed symptoms, and test those people.
And that is the mantra that we have been using. But everyone just took Dr. Tedros' statement, test, 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 totally out of context. He said, test, 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 all symptomatic persons, isolate them and treat them. And that is why our numbers are realistic numbers and not artificially high numbers. So I think both CMO and I are happy for the opportunity once again to explain to the public. And prior, I think we must thank you for bringing up the issue again.
Thank you very much, Minister. Guardian Media Limited.
All right, good morning, everyone. Roshan Khan here from Guardian Media Limited. You all hearing me?
Loud and clear.
Yes.
Okay, great. I just have two questions. So now that we are on the topic of testing, I'm glad that I'm now getting the opportunity to ask this question. It was brought up about a week or two ago by Dr. Nandram about the country going the way of implementing serological testing. Now, I wanted to get some more details. Are we still going ahead with that plan? Because I did not hear you mention anything about that in your previous response. And if we are going about with that, can we have some more details, the logistics? How are we going to implement this, and why it is that we are now starting this type of testing when experts locally have been calling for it since the beginning of our pandemic experience? And now my second question is, I'm hearing some whispers that a possible suspected case of COVID-19 may have died at the San Fernando General Hospital. So I just want to know if you all could confirm that.
CMO?
Okay. So in terms of your first question, the recommendation from WHO has always been that serological testing should be utilized for country surveillance, meaning doing actual research and surveys. So when we have a phase that has already gone, we are looking forward. We were going heavily into the possibility of using our serological testing for just that, to see basically what it is an antibody test. So the PCR test that we're doing now is tests for actual active cases. So it tests from day 0 of symptoms to day 10. Serology usually gives us some results from day 10 and onwards, sometimes with the best kits, maybe up to a month in terms of time picking up your antibodies, different types of antibodies based on what level of infection and the phase that you are at, IgM and IgG. So the use that we want to apply it for is basically to do possible research and surveying of the population to see if there's any level of cross-reactivity of immunity. So as you know, coronavirus is a family of virus, belongs to a family of viruses. We have had, other than COVID-19, we have had other coronaviruses in Trinidad for many years. So we wanted to do a survey to see if there's any cross-reactivity, if there's any hidden immunity for that coronavirus species that is giving us some level of immunity in the population for COVID-19 based on what we had circulating in the population prior. So that's our main use of the serological testing. And you asked why hadn't we used it before? As you know, this is a brand new virus. It's only 7-8 months into the world. So the tests that were really were being manufactured for serological testing in the early days lacked specificity and sensitivity. They were giving something like 30-40%. Now we have better kits because we have more experience with it. We have more time to develop those kits. So they're getting up there in the 90s, which is where we want to see it. So we think now is a good time to use those better kits to tell if we have immunity in the population, what level of immunity we have. And then, of course, for older cases that someone would have had disease 2 weeks ago, recovered, it might be useful to test those individuals to see if they may have had some antibodies in circulation.
Let me just further color and clarify what the CMO has said. As a policy maker in all of this, the same way I just spoke about the misunderstanding of Dr. Tedros' statement, in the early days of serological testing, the testing was wholly inaccurate. And that is why we didn't latch on to that bandwagon and resisted the pressure both externally and internally. If we had done that, those early tests were about 50 to 75% inaccurate. Could you imagine the disaster that would have befallen this country if we relied on that high level of inaccuracy? 3 months later, the situation has changed. The kits are now more accurate. And because of that, we're in a position now, based on the latest technology, to start to talk about introducing serological testing. So Richard, again, like prior, we are really grateful for this opportunity to clarify the issue of testing. Thank you very much.
Okay, and I think he had a second question regarding a death in San Fernando General Hospital.
Yes.
There's no, besides the 8 deaths that we have so far, there has been no death linked to COVID-19 in Trinidad. Just to go a step further, last week I confirmed with the Director of Forensic Sciences Center that they continue to swab all of their out-of-hospital deaths. So those would have been sent all along to the Trinidad Public Health Agency and onward to Caribbean Public Health Agency for testing, and that continues. So that has never stopped. So we're just keeping an eye on the deaths, particularly that are occurring outside of the hospital setting, in addition to those in hospital, to make sure there are no deaths that are occurring, especially in the population outside the hospitals, that are linked. And those are usually red flags that give us some idea of spread in the population.
CMO, could you see if any of those tests were positive
no,
or
none of them
negative?
None of
all of them
were
were
negative so far.
Negative.
Yeah.
Okay, good.
Okay, Minister, there's a rumor amongst the media at this time about, is there any new regulations with regard to schools?
No. Thank you. So the only new regulation that has come out over the weekend was what the Prime Minister announced on Friday, that group sizes will be decreased from 25 to 10. I believe everything else remains the same. Speaking about rumors, there's another rumor. This country is full of rumors. Remember in the early days, there were these rumors amongst politicians, people, that there was no PPE in the country. That is another rumor that is circulating. We are well stocked with PPE. However, the same plea we made then is that we need to be cognizant of the fact that as the population moves and moves unnecessarily to go to social gatherings, we want to keep our healthcare workers safe. We want to keep them safe. Don't put healthcare workers in the position where they have to treat cases because people go to all fours matches, goes to this social thing, spending long hours in places of gay abandon, and then you take the virus home to your children, you infect your children, they go to school. There's a ripple effect, there's a chain effect that irresponsible behavior, which is now creeping up, is starting to show itself. So we ask people, be responsible in how you leave your home now. Go to work, yes. Go and visit your parents and so on. Go and exercise, whatever. Play a little sports. But ask yourself, do I really need to be in a bar for 3 hours? Do I really need to be in a birthday party for 4 hours?
In crowds.
Do I really need to be in a crowd for 2 hours? Because the definition of close contact is 15 minutes with somebody within 3 feet of that person. Do I really need to go down the islands on a boat with 20 people? Do I really need to be doing these things? That is the question that persons will have to answer, because it's that type of behavior that will give the virus a chance to jump from person to person. So we are just asking people, and this is a plea throughout the world. This is not just Trinidad and Tobago. Just be responsible. Don't take the virus home to your elderly parents, grandparents, and or your children. Thank you very much.
Thank you very much. 98.1.
And very good morning to the panel, ministers, CMO Stephen Cummings, 98.1 FM. I have two questions quickly, one for Minister Deyalsingh and the other for Dr. Hines. Minister Deyalsingh, I hope I'm not, pressing you too much, but I have to ask this question. We're going back again to the issue of testing, and I believe that's going to be a discussion on for quite some time.
We welcome
There's
the
a
opportunity.
group or category of unknowns, and this tells me that there could also be a large group of asymptomatics, persons, in the national community that we don't know of, or who could be or might be carriers. And I'm wondering, how are we going to really cap that unknown group? Persons who basically, refuse to present themselves for testing. Some persons giving false information, as has been indicated, basically uncooperative. Clearly moral suasion and soft talking may not be enough to be able to treat with that grouping. And Dr. Hines, again, I know we are steeped in contact tracing, and the virus is raging, as we know. If we are going to fight the virus head on, we'll have to engage in some kind of sustained testing and research mechanism. But I'm seeing where more frequently you have wastewater testing, postmortem tissue samples, and even saliva, for example, continue to provide additional statistical information on COVID-19 in other countries. I'm wondering if this is also the thinking of your department in going forward in treating with COVID-19.
Okay,
Thank you.
So before the CMO deals with the first question and before Dr. Hines deals with the second question, I would just like to rephrase what you just said. The virus is not raging in Trinidad and Tobago. And that is the type of language that the population then holds on to. There's a big difference between a raging virus and the number of cases that we are seeing. So as exemplars and as opinion leaders in society, I think we have to be very, very careful in how we term what is happening now. There is no raging increase in the number of cases, and I'm sure the CMO and Dr. Hines will agree with that. So I just want to put that out there for the public. Yes, we are concerned, but there is no raging increase in the number of cases. There is no cause for panic, as I have said, but we are concerned. And let me just say again, the simple public health measures, masks, sanitization, distancing, stay home if you are ill, will prevent a raging increase. So CMO, over to you.
Yeah, so your question lies in a large asymptomatic pool wondering about basically spreading this thing to the population. The information that we know, and as again, COVID is brand new, 7 months old, we have information changing every day in terms of what the virus is, how it can present. Asymptomatic, what we thought in terms of lack of smell, lack of taste, is a symptom that a lot of people were saying they were asymptomatic in the early days. So new symptoms are being ascribed to this disease every day. We have neurological manifestations, loss of feeling in certain parts of your body. Those kinds of things are new symptoms that one may miss and have been ascribed to asymptomatic. So having said that, if we break down the way persons present, we know that 81% roughly of 100 persons presenting will have mild symptoms or very limited symptoms, maybe runny nose, maybe some symptoms that are like a normal viral illness and will resolve. 14% roughly will have moderate to severe disease, meaning they have some difficulty breathing and they have some other clinical processes that force them to usually seek some sort of health care. So if we have that sort of, and of course 5% of those individuals will be critical. So if you have a pool of 100 individuals somewhere with asymptomatic, what you're describing as asymptomatic disease, A certain percentage of those individuals will present to our facilities because they will be moderate to severe. And of course, another 5% will present with critical disease. That is why we continuously have surveillance at all our health facilities. Those persons that present will belong to either mild, moderate, or severe categories, and we epilink them by going backwards, trying to find the clusters of asymptomatic people if they exist. Now, that is where our contact tracing comes in, and it has to be extremely robust, and it relies on a patient history. So the links start from when someone presents to our facility as a case, they're tested, and then we go backwards to see where the links are. So far, as Dr. Hines has said, the majority of our cases that have presented, we have linked them to primary, secondary. We have been able to quarantine primary, secondary, and tertiary contacts. And in those groups, we continue to test to see if we pick up asymptomatic carriers. Thus far, I don't think we have picked up any large number at all of persons that would have been asymptomatic and been positive by COVID-19 nasopharyngeal swab. There may have been one or two individuals that in primary contact, for example, household individuals with very mild symptoms that some may categorize as asymptomatic, but to the most part, the way we do it is when you present, we pick those up and then we trace rapidly and widely so that we will ensure that even the asymptomatic people in those groups are quarantined and then, of course, tested usually at day 1 and then at day 13 or 14, just before they leave quarantine if you are primary contact. So I'll pass you over to Dr. Hines, I think, to answer the second part, which is linked in some way to what I just said.
Dr. Hines?
Thank you. Thank you for the question. I'd like to just make another point or add on to the points made about the testing before answering the direct queries of Mr. Cummings. And what we need to emphasize, or people need to understand, is that the strategy that Trinidad and Tobago has employed is what you call purposive testing. We have not been attempting to test random asymptomatic individuals because that's not the best use of your resources, and it gives you the wrong picture with regard to what's going on in your population. What we have done is that we have offered testing to anyone with any viral symptoms at this point in time. We have been encouraging persons over the past several weeks to come in with any viral symptoms and to submit for testing. Now, it's a choice that persons make. We have found initially that people may not have been as willing to have the test done, but we're finding that that is changing as the level of perhaps concern is rising in the population. So more people are presenting. So we have 3 sets of people actually being tested. We have people who we know are directly in contact with a case, and those people are tested whether they are symptomatic or not. We have the people who are symptomatic and are not necessarily known to be in contact with a case but have presented for community testing. And we have the people who are coming in via the repatriation process and they're being tested, again, symptomatic or not. So it is not that we are excluding asymptomatic people, but we test asymptomatic people when there is a relevant exposure or a reasonable belief of a relevant exposure. And in that way, we make sure that we have the resources to continue testing through our contact chains. Now, to add to that, when we test forward through the contact chains, we test persons who are symptomatic down to the secondary or tertiary level of contact as a matter of course. We test all the people who are in direct contact with a case as a matter of course. So there isn't a lack of testing. There isn't a magic number or proportion of the population that should be tested. What we are doing is we're utilizing the resources in the best possible way to ensure that all the persons who can benefit from testing do so. And what we have found is that among the persons who have come in with minimal symptoms or with viral symptoms but no known exposure, the vast majority of those persons have been negative. So a lot of the viral illness that is presenting was still not COVID-19. Persons roaming around with viral symptoms have had other things and weren't COVID-19 positive. We've seen the utility of our contact tracing testing by the number of contacts that we have identified as positive, and this has allowed us to expand our contact rings and get ahead of potential chains of transmission. So the information that persons may be comparing Trinidad's testing performance against other countries, that isn't necessarily a relevant comparison, and the strategy that we have employed has been working. Now, to answer specifically the question on wastewater testing would suggest that there is some kind of COVID-19 somewhere in some part of the population. That's all it's going to tell us. We already know that. So there is no real point to wastewater testing at this point. What we need to do is do more specific and targeted testing of persons with potential exposures. I hope that answered the question. I'm not sure if there's another bit that was referred to. If there was, then please just jog my memory.
I think you have answered the question. Thank you, Dr. Hines. TTT?
Good morning, everyone. My question can either be answered by the CMO or Dr. Hines. I'm hoping that someone can share with us exactly how many schools have been ordered closed by the Ministry of Health as a result of suspected COVID-19. And the other question is with regards to how many people are so far considered compromised as a result of these closures. Thank you.
CMO?
Okay, so after yesterday evening, I believe we were 7 or 8. We're close to 9 or 10 schools so far. I asked my epidemiology unit, Dr. Nandra Monday, to actually give me a figure because I recognized 2 other schools were closed this morning. So it is close to 9, I believe. But I will get a definite figure back to you if I can. Dr. Hines, in terms of the total number of people, I don't know if you have a count, if you want to.
Dr. Hines?
At this point, it's a running tally as we expand the contact tracing. More persons are being added to the list. So we know that where schools were involved, there's sometimes a couple hundred people that may be automatically included in the quote-unquote compromised, really just primary, secondary, or tertiary contact ring. Under normal circumstances, one individual may have 5 or 6 really close primary contacts, and each of those in turn may have around the same number. So with each ring outwards that we move, we have an additional multiplicative factor. We are still collecting information on the absolute numbers that have been directly identified as compromised, and as soon as we have a finalized number, knowing that we don't have them all yet, we will actually make that information available.
Before we go to the next question, I want to go back to this issue of testing and this whole theory that we are not testing enough. The United States has a test per million population of 181,298. Brazil has a testing rate per million of 61,573. UK has a testing rate of 242,929 per million. The point I'm trying to make, there is no standard put out by either WHO, CDC, or anyone that says all countries should achieve a testing rate of X per million. So when you take these numbers, you have to take them in isolation. So the constant chatter about Trinidad and Tobago's testing rate, there is no standard to compare it against to say it is high or it is low. For argument's sake, Trinidad's testing per million is about 6,000 tests per million. Ethiopia is 3,856. So in comparison to Ethiopia, we are doing well, but there is no standard. And I just confirmed with the CMO, there is no standard that says all countries should achieve a testing rate of X number per million population. And for all the reasons we have outlined before, our testing strategy has always been in line with WHO's recommendations. So I hope that adds further clarity to testing. Thank you very much.
Thank you, Minister. TV6.
Good morning, everyone. Urvashi from
Morning.
TV6. So just to get back to the SCA matter, so given that clusters have been identified in schools, and I think my count was 9 schools in about 10 days, Dr. Pasram, as Chief Medical Officer, I'd like to know what was your advice to the Ministry of Education as it relates to SCA and SCA preparation classes? That's my first question. My second question, it relates to well, I'm calling it a spike in COVID cases, because we started with about 1 case per day. And I think now we're up till about 5 per day, an average of 5 per day. It came 2 weeks after nomination day activities, which we did see it was a sort of FET-like activity, a Juve-like activity. Those cases came after that. What sort of spike, Dr. Pasram, do you expect after the election? Thank you.
Okay.
CMO.
All right. So the advice, the Ministry of Health continuously makes recommendations to multiple stakeholders, including the Ministry of Education. We have education reps on our multi-sectoral committee. We will continue to do so, but matters related to schools and examination lie with the Ministry of Education, and I cannot go into further detail until they have had that information and made a decision. So the ministry will continue to make its recommendations going forward. As it relates to the spike, again, we continue to monitor this thing on a minute-to-minute basis, on an hourly basis. Yesterday we would have had 2 cases, which was basically one known contact, and there was one new person, which on the form that we got, which is the TPHL form, there was very little information filled out by the clinician. So we weren't able at the outset to say whether it was linked or unlinked. So we're in the process of tracking that particular case down to see whether there's a link to any of the previous cases over the last couple of weeks. So yesterday was a good day in my view. And as I say, every hour I get the results from the Caribbean Public Health Agency right away, straight from the virologist. We cannot project 1 or 2 or 3 or 5 days into the future. At this point, we have to work with every day as a new day. Our contact tracing is the most critical part of it. Our ability to get information on the primary, secondary, tertiary contacts, have those persons quarantined, because what we're trying to do now is contain the virus. So if we can quarantine all of those primary, secondary, tertiary, test as we need, and have those persons ring-fenced so that the spread is curtailed, that is our goal as now. I don't want to project into the future what is going to happen in 5 days or in 1 week. I don't think anyone can make that sort of prediction at this time.
Let me just come in here again, because Urvashi, you raised a very pertinent issue. Early in our local epidemic, there were unsuccessful attempts to link the first cases with Carnival. Mm-hmm. And the government and the Ministry of Health spent a lot of time debunking that theory. Now you have raised the issue, and you are quite right to raise it. I think, CMO, you will agree, because we spoke about this. The first 2 cases, the people were symptomatic before nomination day, if I could remember. And maybe Dr. Hines could say if he has seen any link in contact tracing to nomination day, because my understanding was that first elderly female was ill before nomination day. So, Dr. Hines, are you able to say if any of your contact tracing can be linked to nomination day activities?
We don't have any information that links the contact tracing to nomination day. What we would like to underscore, though, is that if there are ill persons with respiratory symptoms moving around, that puts persons at risk no matter what day it is. Also, we would like to emphasize that when persons move into spaces where they are likely to come within 6 feet of one another, that we again employ all of the public health measures that were repeated ad nauseum about the hand washing, about the mask use. So we don't have any data that links the temporality of the cases we've seen to the nomination day event. We will continue to look backwards and forwards at information as it becomes available, but nothing links the events at this point in time.
Okay, before we go to the next question, I just got a message from Minister Young. We have to make a correction to the regulations. Apparently, there was an error made as far as schools, when schools are to be opened. It was an oversight, and we will be fixing that. So rest assured that we'll be working with the Ministry of Education to correct this oversight, and we do apologize for it.
Thank you very much, Minister. We are out of time, and we've come to the end of today's virtual media conference. And do remember that the Ministry of Health and the Ministry of Communications are your only credible sources of government information on COVID-19. The Prime Minister will be hosting Wednesday's media conference as we continue to monitor and review the data on COVID-19 in Trinidad and Tobago. Please tune in as we update you on the way forward in this time of the COVID-19 pandemic. And as we go, we want to appeal to you to adhere to the public health regulations in place. Over the past 2 weeks, we have seen an increase in the number of new COVID-19 cases in Trinidad and Tobago, and the advent of clusters, which led to the rollback of some of the eased restrictions. Despite this, many persons have not modified or changed their behavior. In fact, on Saturday, the Prime Minister again issued an appeal to us to take the threat of COVID-19 seriously and to not congregate or assemble in large groups. To political parties that are campaigning, let us be responsible and lead by example. Even as we prepare for general elections, do remember we should not be organizing large groups of persons to walk around neighborhoods, and this provides the perfect condition to spread the virus and lead to an outbreak. We cannot afford to let this happen in Trinidad and Tobago. We understand that political activity in the lead up to an election is essential, but we must conduct those activities using the public health guidelines for our new normal, and mindful that we are still in the midst of a pandemic. This action of denial poses a threat to all. There are many other ways to reach and influence the electorate. Therefore, I am appealing to everyone, particularly those organizing groups, to campaign. Please refrain from violating the public health guidelines. Your actions either protect or endanger us. And let us remember to wear a mask over our nose and mouth when out in public. Let us keep our distance from others. It is recommended that you stay at least 6 feet apart and stay at home if you are ill. And do remember to wash your hands often with soap and water or use an alcohol-based hand sanitizer. And if you cough, do so into a tissue or into the crook of your elbow and avoid touching your face. Please remember that gatherings in public spaces has been reduced to groups of 10, but the numbers for funerals and religious gatherings remain unaffected. And just to remind you again, on Wednesday, the Prime Minister will be hosting the media conference as we continue to monitor and review the data on COVID-19 in Trinidad and Tobago. I am Donna, Minister of Communications. Thank you for joining us today as the government continues its efforts to keep the curve flat and beat COVID-19. Stay safe, save lives. May God bless Trinidad and Tobago.